your colleague consultant of anterior segmental uveitis at King Abdullah bin Abduaziz Hospital, Princess Noor University. It gave me a great pleasure to present this extremely important topic about the peripheral ulcerative keratitis. And we will be starting by talking about the distinct morphology and immunology of the corneal limbus. Understanding the distinct morphology and immunology will help us understand the pathophysiology of the peripheral ulcerative keratitis. We know that the central and paracentral part of the cornea is completely devoid of the blood supply and completely avascular. Depends on the aqueous to take its nutrients and nutritional supply. The peripheral and the limbal part will take partly the nutrients from the perilimbal blood vessels. And from there, the pathophysiology that affects the limbus and the perilimbal area is totally different from those affecting the paracentral and the central part of the cornea. Now, when you look at the limbus in the peripheral cornea, as we mentioned, it obtains part of the nutrient supply from the anterior conjunctival and deep episcleral vessels. And these vessels are the precursors of inflammatory cells, immune modulators, and complements that can precipitate and occlude these blood vessels in case of inflammation. When these blood vessels get occluded, leakage and infiltration with WBCs and inflammatory cells happens. Release of enzymes like collagenase and proteinase enzyme causes the signs and symptoms of peripheral corneal ulceration. Now we have to know that normally these vessels extend up to 0.5 millimeter into the clear cornea. And we do have some subconjunctival lymphatics that drain into the regional lymph nodes, and they provide the afferent arm of the corneal immunological reaction. And when we want to define the peripheral corneal ulceration, PUK has never been a diagnosis. PUK is a description of a pathology that is peculiar to the periphery of the cornea. So it is a PUK, P is peripheral, ulcerative keratitis, it is a description rather than a diagnosis. So it has a distinct feature that has to be understood prior to labeling a patient with a provisional workup diagnosis of PUK. There has to be an epithelial defect. There has to be a stromal inflammatory cells with or without stromal degradation. An ulceration might progress either centrally toward the center and the visual axis, or might go circumferentially and follows a special pattern, as we will see. It has a variable severity depending on the cause. The PUK that is associated with the systemic diseases usually tends to behave aggressively. Those with the local diseases tends to behave in more or less virulent way. So there are two entities that has been mislabeled as PUKs. Terian marginal degeneration and pellucid marginal degeneration. And these two entities are not and should never be labeled as PUK because they don't meet the criteria. The criteria is the absence of the epithelium, which is not the case here, presence of stromal infiltration, which is not the case, with stromal melting, which is also not present. These are non-inflammatory corneal thinning and non-ulcerative. So understanding the pathophysiology, prior to the PUK, there has to be some sort of inflammation, infection, trauma, malignancy, local or systemic immune reaction that triggers the immune system to attack the periphery of the cornea. This is followed by complement activation as part of the immune reaction and immune complex deposition. Neutrophils and macrophage will be recruited, T1 helper and T helper 2 dysregulation, and this will lead to the release of proteases and collagenases. These enzymes are degradation enzymes. They are going to melt the peripheral stroma and their overlying epithelium. There will be a vascular permeability. There will be a release of matrix metalloproteinase from the keratocyte that will add insult to the existing injury. Now, the image will be almost like this. This is a classical picture of a chronic case of peripheral ulcerative keratitis, melting, thinning, and degradation. Now, when we would like to approach a PUK, we have to know whether is it because there is a coexisting systemic condition, or it's just an ocular condition. Ruling out systemic condition is of very important. Is a very important step. Systemic infection like gonococcal, TB, syphilis, and dysentery are the commonest 4 causes of infectious diseases that causes a peripheral ulcerative keratitis. The non-infectious causes are mainly the autoimmune. It could be a vasculitic disease, which carries the worst prognosis in terms of mortality, not even the morbidity, and a group of inflammatory bowel disease and malignant diseases. The ocular condition, the most commonly, is a bacterial infection, namely streptococci, staphylococci, or even Haemophilus influenza. Viral infection is a well-known and recognized causes of PUK, namely the herpes zoster and herpes simplex virus. Fungal infection and parasitic infection has been found to cause a PUK as well. The non-infectious ocular causes could be because of trauma, that is either surgical or non-surgical, keratoconjunctivitis sicca, eyelid abnormalities like blepharitis, entropion, ectropion, or it could be an idiopathic like Morin's ulcer. So Morin's ulcer is the last of this list. So nobody should be labeled as Morin's ulcer till we have a completely negative systemic and local workup. Now, the presentation is very variable, and this depends on the etiology. Most patients present with visual acuity reduction. They present with variable degree of pain and redness. The classical teaching presentation is it is a crescentic shaped corneal ulcer. It is a crescentic because it takes the configuration of the limbus. It occurs within the 2 millimeter of the limbus, which is the area that is on the hand of the supply of the peripheral blood vessels. There will be a corneal epithelial defect in association of stromal thinning. Sometimes stromal thinning preceded the infection. Sometimes the infection preceded the epithelial defect preceded the corneal thinning, and this will help you to formulate your differential diagnosis. For instance, cases of marginal keratitis started with stromal infiltration and thinning, followed by corneal epithelial defect. Cases of PUK secondary to viral infection started usually with an epithelial defect, followed by stromal thinning. Stromal infiltrate involving the adjacent conjunctiva and sclera can be found, and this sign has to be mentioned whether it is positive or negative. So absence of involvement of sclera is a very important sign. It has to be mentioned in the patient file, so you can shortlist your differential diagnosis. Scleritis has been found in 36% of patients with a systemic disease. Now, we know that variable etiologies have variable presentation. The 4 main questions that everybody should ask whenever he sees a PUK is, does this PUK follow a special pattern? Like the one we see in Morin's ulcer, or the one we see in a marginal keratitis, where you have a band of clear cornea followed by a stromal infiltration with or without corneal epithelial. The second question, could it be a vasculitic PUK? Answering these questions means the difference between life and death, because this is going to predict the prognosis, would help you to decide how urgent is your intervention and how far can you go with immunosuppressants. The third question, is it infected or is it caused by infection? Now, every single PUK, no matter what is the cause, is vulnerable to be infected. So you could have a vasculitic PUK that is secondarily infected. So every single PUK is infected until proven otherwise. Third question is it threatening globe integrity? This is going to tell you whether you would go for a surgical option in association with systemic immunosuppressant or not. So these are the most important questions to answer on the initial evaluation of a patient. Now, for example, this is a picture of a patient with a peripheral significant corneal thinning, vascularization, epithelial defect with adjacent necrotizing scleritis. This is a patient who turns to be a patient with a vast systemic vasculitis, Wagner granulomatosis in particular, and the presence of necrotizing scleritis almost always indicate the presence of potentially lethal systemic disease. Now, we have a PU case with no involvement of sclera, it's just pure peripheral corneal involvement. Other PU case starts exactly at the limbus and the junction between the cornea and sclera. Other forms of PUK starts on the far periphery with the thinning of the sclera more than the thinning of the cornea that is seen on Wagner granulomatosis. And we do see sometimes corneal ulceration that is close to the central cornea, as in rheumatoid arthritis patients. So different presentation can tell and shortlist your differential diagnosis. Now we have to look at the patient as a whole. We shouldn't look at the patient from ocular point of view and deny systemic examination. Evaluation has to be multidisciplinary with a rheumatology or internal medicine team. We have to look for the clinical signs of systemic vasculitis that can tell you the most likely cause of the PUK. If you see one of these, then an urgent referral to a rheumatologist or internal medicine is warranted. The reason is that this patient is going to benefit from the systemic immunomodulators, steroids or biologic agents, in addition to the local treatment. So it is a life-threatening condition that has to be referred on an urgent basis. Now we have a list of lab tests that we have to know, but we shouldn't order them all. We just need to know that these tests are peculiar to certain diseases. Tests will be requested based on the clinical finding, systemic as well as ocular. Now, as we mentioned, that all cases of PUK, we have to do scraping and we have to culture the lesion to rule out underlying infection. Infection could be the cause or could be a secondary pathology that happens overlying a non-infectious PUK. We should not over-investigate. Most of the diagnosis comes from appropriate history taking and evaluation. Now, telling the difference between PUK and Morin's ulcer is telling the difference between life or death. Now, one should not go for the diagnosis of Morin's ulcer. It's a diagnosis of exclusion. We should make sure that this ulceration follows a specific pattern. Those patients with Morin's ulcer, they usually have intractable pain that is out of proportion to the clinical picture. And they have strictly absent scleritis. And all of them, their workup is negative. There is no, place for Morin's ulcer in patients with high ESR or C-reactive protein or any of the inflammatory markers. So this marker has to be negative prior to labeling patients as Morin's ulcer. Those who were labeled as Morin's ulcer, they have a relatively good systemic prognosis. Now, Morin's ulcer has a specific pattern of presentation. They usually present in a concentric shape. They are peripheral at the limbus. There is no scleritis. Presence of scleritis excludes Morin's ulcer. Now, the ulcer itself, it has an undermining edge with overhanging lip. Now, if one of us uses a fine instrument to explore the ulcer, one would find that it has an overhanging lip, and if this fine instrument is exploring the ulcer toward the center of the cornea, one would be absolutely astonished of how far he can get into the center of the cornea before the instrument can meet the resistance. In other words, there is a lot more destruction than is clinically apparent at the slit lab. The intrastromal yellowish infiltrate that is seen is a classical of Morin's ulcer. Reepithelialized and vascularized thin cornea scar in the way of the advancing ulcer. I mean, the ulcer can advance toward the center, and from the back, it can start healing. There has to be, as we mentioned, absence of scleral involvement. And it has been postulated that a prior corneal surgery, corneal trauma, corneal infection are risk factors for development of Morin's ulcer. And whenever Morin's ulcer is mentioned, people will talk about the association between Morin's ulcer and hepatitis. While there have been some reports linking the Morin's ulcer with hepatitis C, there is no consensus on this issue, as there are only few case reports that talk of this association, and there is no good evidence that show that this is a true association. Most experts in the corneal area don't believe in such association and don't treat these patients with anti-hepatitis treatments. Now, there are two classifications of Morin's ulcer. The old classification with type 1 and type 2, depending on the age of the patient. And we have the new classification that talks about the laterality of the disease, in addition to the course of the disease. We have the unilateral Morin's ulcer that usually affects elderly people. It's very painful, and it is progressive. And it's caused by non-perfusion of the superficial vascular plexus of the anterior segment. The bilateral aggressive form of Morin's ulcer happens to the relatively young group of population. It progresses circumferentially and then it goes centrally. They have extensive vascular leakage and new vessel formation, and that extends to the base of the ulcer. We have the bilateral indolent Morin's ulcer that affects the middle-aged people. It is progressive. They have peripheral corneal dottering with little inflammation and no change in normal vascular architecture, except in the extension of new vessels into the ulcer bed. Now, when we talk about therapeutic guidelines, we should know what we have in hand, what options we have in hand. Now, the treatment goal has to be to arrest inflammation, to treat the underlying or associated infection, to protect the globe or to reserve the globe integrity, to restore vision, and to save patient life. These are the main 5 goals of implementing therapies in patients with PUK. We have a supportive measure. We sometimes have a corneal thinning in the periphery that is so severe that patient has to be on eye shield and protective glasses. Bandage contact lens will help to halt the progression and enhance the epithelialization of the periphery of the cornea. Topical treatments like lubricants, antibiotics to treat current infection or to be a prophylaxis against secondary infection is also recommended. It's recommended to use a preservative-free medication to decrease the irritation of the ocular surface. The use of cyclosporin A, the 0.5 up to 2% concentration was also found to be helpful. The lower concentration does not have an anti-inflammatory properties. That's why they are not used in these cases. Anticollagenase agents, we will see them, and steroids. We should apply steroids with extreme level of caution. Steroids can inhibit collagen production and can add insult to the injury. And it should not be used for a long time. It's duration and concentration dependent. It should be used wisely to arrest inflammation on the initial phase of the disease, and then should be tapered and weaned off quickly and replaced by steroid-sparing agents. Now, these are adjunct therapies and not solid treatments. We have a topical anticollagenases like the Provera, the 1% medroxyprogesterone, the gestational steroid. It inhibits collagenase synthesis. The 20% N-acetylcysteine, which is a competitive inhibitor of the collagenase. We also can use a topical vitamin C as an eye drops to enhance the collagen formation. We can use a systemic anticollagenase like tetracycline, but it has been, denied because of its side effects. Doxycycline, the commercially available one, is the antibiotic dosage, which is 100 milligram. However, we have a commercially available low doses of 20 milligram that is sufficient to inhibit the collagenase and doesn't have an antibiotic antimicrobial action. Oral vitamin C is of helpful value. We can give up to 1 gram daily to facilitate the corneal healing. Now, topical cyclosporin in conjunction with lamellar-keratoplaster was noted to improve the healing rate in morning ulcer. And this was found in a Chinese study. Systemic immunomodulator agents like methotrexate, cyclophosphamide, cyclosporin, and azathioprine are only indicated if you have a PUK associated with a potentially lethal systemic vasculitis, or you have a PUK that is associated with a necrotizing scleritis, vasculitis, or refractory PUK to the conventional treatment, or if you have a patient with a bilateral or aggressively progressive Morens ulcer. These three main indications for a systemic immunomodulators. We can combine therapy. Steroids has the advantage of massive suppression of all of the immune system in the early phase of inflammation, and then it has to be weaned off quickly and then replaced with the immunosuppressant, other immunomodulator that has to be started on the same time. It may take up to 4 to 6 weeks for the immunomodulator to reach the peak effect. They usually start at 2 weeks, but they reach the peak effect of their immunosuppression at nearly 4 to 6 weeks. Oral steroid is used temporarily to stabilize the inflammation until the immunomodulator takes over. Now, if the initial combination is ineffective after several months, then the patient will be switched to a different agent. Some patients, they respond to a certain immunomodulators and others, they don't. For instance, Wagner granulomatosis and the polyarthritis nodosa are particularly responsive to cyclophosphamide when it's combined with systemic steroids. Oral cyclosporin, for example, is not effective in treating cases of PUK. It's more effective in treating intraocular inflammation instead. So the cyclophosphamide is a drug of choice for almost all PUK associated with a connective tissue disorders. Now we have to know about special considerations when we consider immunosuppressant. We have to monitor patients in terms of their CBC profile and their bone marrow function. We should be aware that we are putting those patients at risk of secondary infection with an organism that can be lethal, like pneumocystic cardiac pneumonia. Most of these considerations will be done in conjunction with the internal medicine specialist or the rheumatologist. We have to be also aware about the glucocorticoids-induced bone loss, and it should be monitored and treated if needed. The biologic agents are an excellent standard for treatment. Some physicians, they consider it first line in people who are relatively young and healthy, who do not have a heart, liver, or renal disease, and are not in a risk of reactivation of an indolent infection. Infliximab has been tried to treat rheumatoid arthritis associated scleritis and PUK, and the effect is seen within 1 to 2 weeks after the first dose. The etanercept is less effective than infliximab. Rituximab is used for refractory PUK associated with Wagner granulomatosis. Now, surgical treatment of PUK is reserved for those patients with impending perforation to preserve the globe integrity and not to restore vision. A cauterization or surgical resection of conjunctiva has been tried. The perilimbal conjunctival resection will remove the immune complex deposition, will reduce the immune complex deposition at the periphery of the cornea, will decrease the production of collagenase and proteinases. But the problem is that PUK might recur once the conjunctiva grow back. So a combination of surgical options depends on the size and of the perforation. We could use a bandage contact lens. We could add a glue, fibrin or cyanoacrylate glue. ANT also can restore globe integrity, corneal integrity, and also can downregulate many of the inflammatory enzymes released during this kind of inflammation. Capsulorrhaphy also is also a valuable tool. Tectonic surgeries like corneal patch graft, lamellar, concentric, corneoscleral, or hemipatch graft is indicated when you have a perforation of more than 2 millimeters that you cannot secure with a conservative treatment. Unfortunately, the outcome is very disappointing. All those patients need to be regrafted in future because they do have a risk of rejection. The graft is in the periphery. The graft is being done under inflamed condition. Now, the therapeutic response also is variable. This is a patient who presented with a peripheral extensive PUK with vascularization at the periphery. Was started on a depot of methylprednisolone to arrest the inflammation. Within 12 hours, inflammation started to subside. In 3 days, the cornea started to heal. Now, this is another case. This is a 15-year-old girl presented with progressively worsening pain and redness on her left eye for 2 months duration. She reported a history of otitis media, attacks twice in 1 month. She had weight loss, low-grade fever, fatigue, and malaise with recurrent epistaxis. Our ocular examination showed this deep scleral injection, the dilated perilimbal vessels, presence of corneal epithelial defects, and in association with corneal thinning. She was found on lab to have a high level of C-reactive protein. ESR was extremely sky high. She came positive with C, ANCA, and her CT of the chest showed a nodular parenchymal lesion without cavitation. She was diagnosed with a Wagner granulomatosis and was started on appropriate treatment, systemic steroid in association with cyclophosphamide, and she had a very good recovery of the ocular condition. Now, this is a slit-line appearance of a PUK with a scleritis, pre-treatment and post-treatment with cyclophosphamide in a patient with Wagner granulomatosis. This is an image of a patient with rheumatoid arthritis-associated PUK who developed a perforation, and that perforation was seen with cyanoacrylate glue, and then bandage contact lens was applied. Systemic immunosuppressant continued, and patient developed a good healing at the periphery of the cornea, and no further intervention needed. Now, viral PUK, we know that herpes simplex and herpes zoster can cause PUK, even in the absence of dermatological finding. It's limbal vasculitis induced in kind of inflammation. Even if you do culture of corneal scraping, it will come negative. You only can diagnose them when you send it a biopsy for PCR or limbal conjunctival vessels by immunoprobing. Those kind of patients, you have to have a very high index of suspicion to diagnose it. It will make it easy for you if you have an keratitidis in association, if you have reduced corneal sensation, or if you have a patchy iris atrophy that will aid you to have to go for this kind of differential diagnosis. Now, topical steroids in association with antiviral agent can give good results. Now, if you have a perforated PUK, then patch graft is warranted. I mean, it's inevitable. You have to go for a patch graft regardless of the outcome, because your aim here is to restore globe integrity and not to restore vision. And then you can have a regrafting or visual rehabilitation later on. The corneal patch graft has always to be started with the appropriate immunosuppression. Nevertheless, the outcome is disappointing. Now, to put everything together, the corneal limbus, as we know, is predisposed to various pathological conditions because of its distinct morphology and anatomy. The first visit is the most important visit. Please spend generous time to obtain a detailed personal and family history from the patient. The patient has a lot to tell you and will save you time, will save you money, will save your unnecessary investigation by taking appropriate history and conducting appropriate slit lamp examination. The goal of treatment is to arrest inflammation and then to preserve ocular tissues and to control the underlying systemic disease. The initiation of appropriate immunosuppressive therapy with the steroid and cytotoxic agent is a life-saving and not only vision-saving. Biologics have recently become more important in the treatment of cases refractory to conventional immunomodulator therapy, and sometimes could be the first-line treatment in a patient with a very severe presentation of PUK, and they have a good health. They can tolerate the side effects of the biologics. So thank you, everybody, and for listening. And this is the end of the presentation.